All right, so we are live. Good afternoon, everybody. This is Dr. Michael Kaye from the Center for Functional Health, and today I have the honor of interviewing Dr. Patel. Dr. Patel, welcome. It's great to have you here.
Thank you. Very excited to be here.
So I love the fact that we got to meet. You have opened up an office. You're going a very interesting route. You're doing a concierge neurologic practice, which is absolutely fantastic. So I want to learn more about that. But before we dive in, if we can learn more about like, hey, what is your history, what your journey's been like, and like how you got to this point here, why you picked neurology.
Yeah, so going back as far as I can remember, maybe even middle school, I've always really just been interested in science. I did a neuroscience major at the University of Pittsburgh, so kind of just stuck with that theme, and just always been intrigued by the brain, the complexity, um, just how much it controls in our body, and the ability to combine that with my love for sports and treat patients with brain injury and headaches is really how I ended up where I am today.
Gotcha. And would you say like with the sports, we're just seeing a lot more injuries in sports now than ever before? And is there one sport that just takes top notch? Like, are we just seeing it still in football? What happens to people who do like MMA fighting and all that, boxing?
I don't know if we're necessarily seeing it more as much as we are more aware of it. I think that both athletes and just the general population, providers of any kind, they're more aware of what a concussion or what a brain injury is or the signs to look for. Whereas previously, I think a lot of it was misunderstood or not well understood. And I'd say you really see it with any combat sport, any sport that involves any sort of significant or even minor impact to the head. Even in sports like soccer, where players are heading the ball, you wouldn't think that that would cause an issue, but there are studies being done on, what happens with each of those subconcussive hits, and what are the long-term effects of those.
Gotcha. And not to go off track, wasn't there a study that came out some time ago with in soccer, football, wherever you're from, however you like to call it, that the heading of the ball, the head injuries leading to more of that ALS kind of presentation? I think there's something else out there like that. Um,
So, I think it's hard because we're still learning more about those subconcussive hits, right? Because I think that one of the biggest challenges I face up front when someone comes to see me is, did they actually have a concussion, or was it just labeled a concussion, and now we're down that path? But there are a lot of folks who have these subconcussive hits that we're still learning more about what kind of downstream effect they have when you accumulate these over time.
Gotcha. And moving away from the sports, I mean, the folks I see in the clinic, these are people who fell, hit their head, motor vehicle accidents. Even when there's not an impact, they still walk away with an MTBI, and it's like, okay, they're not doing well. So when you see that, is that assessment any different than the sports person? Like, are you seeing something strikingly different in sports versus somebody who just hits the back of their head or something?
No, I really approach them all the same way. The goal is to first get a better understanding of what the injury was, and you're right, you don't need to hit your head to have a concussion. You don't need to lose consciousness to have a concussion. So I frequently see people who are in motor vehicle accidents who have a whiplash injury, and just that quick back and forth motion of the head and the neck is enough to put force upon the brain and cause the effects that would come with a concussion.
Gotcha. So one thing I want to do as we dive deep into this is to talk about the brain physiology. So we can talk about a little bit of the anatomy. We're talking about the temporal lobe, parietal lobe, we're talking about the cerebellum, all that kind of just general physiology to share with everybody. Like, hey, this is what this side of the brain does. This is what this front side of the brain does, and what happens. What you see with injuries to these different areas.
Yeah, so that's a complex question.
It is,
So
and
the
you have
way the
five
way
minutes. Go.
the way I like to just think of it is like the brain is this city, and you have all these highways in the brain, which are the synapses, the axons, the neurons. Those are transmitting all the signals across the brain, and all the different parts of the brain are the different towns in the city, and they each have different responsibilities. And when you have something like a concussion or a more significant brain injury, the area of the brain that's impacted can produce a different set of symptoms depending on what area was impacted. So, for example, The frontal lobe can be involved with some executive decision making. It can also impact personality change to some extent. And if you have someone who has that sort of coup contra coup injury, which is where when you have impact to, let's say, the back of the head, that doesn't necessarily mean that the back of the brain is getting impacted because the brain is sort of free floating in fluid. So when it shifts forward, the front of the brain can get impacted and produce some of those symptoms. And so you really want to look at the whole picture. You want to look at the mechanism of the injury, but then you also want to dive into it a little bit more and get a better understanding. Well, okay, what side of the head was hit? Which way did your head move? What was impacted?
Gotcha. And if we're going to dive deeper in that, when you're doing your exam, what is it that you're looking for that makes you think one portion of the brain physiology versus another portion? What are you seeing clinically?
I'm really just asking them one about the different set of symptoms they're experiencing, and then kind of just looking at it with a kind of a broad view. So not necessarily diving into the nitty gritty of each and every part of the brain with them, but um, just asking them sort of general questions about their thinking, their mood, their behavior, to help me sort of narrow down what I might be dealing with.
Gotcha. And we do see those mood changes, with the concussion patients, like largely in a sense, aside from being a level of irritability because they're injured and they don't feel well, but they don't have that kind of bounce back. Things bother them a lot more. We'll see that. Aside from like lights, sounds, all of those that cause them to have an issue. So when they go in the big box stores, they feel that sensation, that wooziness. They'll feel headachy. Sometimes they can even feel like that heart palpitation. We tell them to wear their sunglasses because, when they go in, there's just so much coming in at one time. They feel like their brain is just like, they tell me like it feels like they're vibrating.
Yeah, yeah. I mean, there's a long list of symptoms that come with these sorts of injuries, but that sort of overstimulation, the way you're describing it, is very common, and I think that plays into a lot of the other symptoms that they have. And for a lot of the people that end up in my clinic, they've had their injury weeks, sometimes even months ago, and they're still struggling. Um, and I think that drives some of that overstimulation, that anxiety or stress piece to it as well, because they don't feel like their normal self.
Gotcha. So they come to your clinic. It's 3 months, 6 months. It's 2 years, and they're still struggling. Maybe they had some scans. Maybe they didn't. Can we talk a little bit about what scanning you feel provides the most information for that concussion patient? Because a lot of times they'll do the scans and it's negative, right? So
Yep.
then what happens?
Yeah, so concussion is not a physical structural injury to the brain. It's a series of chemical changes that happen in the brain. So when you get things like CAT scans or MRIs for someone who had a concussion, who truly had a concussion, they'll be normal from that standpoint. There may be other incidental things that you'll find, but from a concussion standpoint, you won't typically find any structural damage to the brain. So when someone comes to me months, sometimes even years, like you said, after their injury, my job's to sort of tease out, well, number one, let's go back to the injury itself and clarify, was it an actual concussion? Um, was it a more significant brain injury, depending on their symptomatology up front? And then really parse out all the different symptoms that they're having. So I ask about their headaches, I'll ask about sleep, I'll ask about mood, if they're having any sort of dizziness or balance issues, that they're thinking. And I dive into each of those categories because oftentimes the lingering symptoms we see are related to some combination of those symptoms going on.
Gotcha. So it's nothing that we'll see on a test. Will you run another test? Will you order another test? Is there anything that you're looking for from a scan perspective? And if it's not, it's not going to be. Will you get anything from it that's going to move that clinical needle forward? Like, okay, you saw this, and now you're going to think, okay, I'm going to do this kind of a treatment, or it's just all taking in from just a really good history, which a lot of times, as you well know, docs don't always have the time. Hence your creation of your practice to treat the way you want to treat, to really dive in deep.
Yeah, so the clinical portion, listening, that is huge. That's probably the most important part of what I do. Um, if someone comes in with persistent symptoms, I'm not saying that it's futile to order an MRI. I think the MRI is beneficial in that standpoint because it gives us some reassurance that we're not missing any secondary cause of their symptoms that may have gone missed. It gives me reassurance and the patient reassurance that there's nothing big or structural going on in their brain. I often get a series of basic labs because I find that concussions frequently bring out symptoms related to deficiencies that were present before their injury. I see a lot of people who had symptoms of sleep apnea prior to their injury, but it really wasn't impacting their day-to-day functioning. But now, post-injury, their sleep quality is so poor, and those symptoms related to possibly sleep apnea are right at the forefront, impacting their recovery. So, I check those things. If cognitive issues are a big part of their presentation, which is something common that we see, brain fog is the way people will describe it. Neuropsychological testing can be very helpful if it's been months after their injury. These are usually PhDs that take a really deep dive into someone's thinking, their memory. They'll parse out their past history, and they'll give me a very comprehensive report in terms of what could be contributing to lingering symptoms as well.
Gotcha. So I'm going to dive into two things. My brain's going in two directions. One, the neuropsychiatric evaluation. When that information comes back, what do you do with it? That's number one. Number two, we're talking about the importance of sleep. So we're talking about the importance of sleep. If you can review the glymphatic system and why that's important.
Sure. So, um, neuropsychologists to me are so important when it comes to persistent symptoms, and they are hard to find and hard to get in with.
Hard to get
It can be
into.
yes, it can be a very long wait, but they're so helpful because they will spend hours with you just talking to you about your history, your injury, any comorbid medical conditions. And what they do at the end is usually give me like a 10, 15, 20 page report kind of detailing everything they talked about and then all their assessments and recommendations. So if there is a behavioral component to their symptomatology or it exacerbated a pre-existing behavioral health history, they'll give me recommendations of what might be recommended there, whether that's seeing a therapist or going to a psychiatrist, considering medication management. If there's a sleep component or um, some other piece to it that they've covered in their hours-long evaluation, they'll usually give me a list of recommendations. Oftentimes, I've already done some of these things, like incorporating occupational or physical therapy if they haven't had that already, or if they haven't had it tailored to what we need. Um, so there's a lot of different pieces to what they can offer. And then on the glymphatic system, so I'm glad you brought that up. So the glymphatic system is basically like the um, waste disposal system of the brain. So the body has the lymphatic system. The brain developed its own system called the glymphatic system. Very unique name. And essentially, what it does is it clears the brain of all the waste products, and it works best overnight. So that's when it's most active. So we frequently see people who don't get good sleep or poor quality sleep, poor quantity sleep. When they wake up in the morning, they feel very foggy, and the poor functioning of the glymphatic system is likely playing a big role there. So that's one of the thought processes behind persistent symptoms after concussion because we frequently see sleep disruption after these injuries. So if these folks are not getting good sleep, it's likely impacting that waste removal system, and that's probably in some part contributing to their fogginess.
Gotcha. So if we're going to stay on the thread of the waste removal system, and we don't really have a way to test or gauge that, right? So, correct, we don't have a way to really
Mhm.
assess how it's doing other than this subject of complaint. Then comes in, okay, we got to get like a sleep study done, which is great. We want to see if that sleep is fragmented and makes sense. So what, and obviously CPAP, if there's a airway obstruction, that makes sense. We'll see that after, especially like motor vehicle injuries and all that kind of stuff. what then can we do to help them sleep? Like we already said that there's a neurochemical imbalance in a concussion. Do we really want that person to, go on a sleep pharmaceutical agent, or is that gonna backfire? Is that gonna make them more loopy, more brain fog, that kind of stuff?
Yeah, I mean, I think that's definitely something we absolutely take into account. So we don't necessarily need to use medication to treat a lot of things, but if it comes to that point, we definitely want to take the side effect profile into account for anyone who has brain fog or some other cognitive issue because you don't want to make it worse. And most sleep medications, supplements may have some sort of negative impact from that standpoint, so you really want to be careful there. I'd say the first thing, like you said, is get an idea of what's going on with their sleep. Is it poor quality sleep, so they're getting 7 or 8 hours, but they just wake up feeling like they didn't sleep at all? Is it poor quantity, where they're only getting a few hours per night? Is it very broken up? Um, I think a sleep study is a great idea. I think I order a sleep study on pretty much everyone I see, if I have any suspicion of some sort of sleep issue, because I want to make sure there's nothing like sleep apnea going on. Um, and really, what I use a lot of is cognitive behavioral therapy. These are behavioral therapists geared specifically towards the treatment of insomnia, and that's the gold standard for treatment of insomnia. So rather than prescribe medication for these folks, I find a cognitive behavioral therapist to kind of work them through the insomnia rather than just give them medication.
Gotcha. So I'm gonna have to share with you Empowered Sleep. It's a wearable. I think you'll find it interesting because I was able to assess not only like heart rate and O2, but also my fragmented sleep, and I was able to push the fragmented sleep in different directions, getting better sleep by either changing what I was eating, changing if I was taking a supplement or not. So it's very because when we improve the fragmentation, that's when things started to improve. So I'm going to assume that's the same thing for our folks who have the brain injury from an MTBI, headache, all that kind of stuff. I think you'll find that interesting. So in our world, supplements, everybody wants to move to that melatonin, and it's not always like the greatest thing, right? So obviously, producing the pineal gland and all that, but it sometimes it doesn't push the sleep in the right direction. And a lot of times, I don't know what you see, they'll end up taking too much, or they're not taking a sustained release. So can you talk a little bit about the supplements, if you ever deal with any supplements, and because sometimes you want to be careful dealing with a supplement for sleep, especially if they're doing something already for the sleep from a pharmaceutical perspective.
Yeah, so I use melatonin infrequently. I agree. It's very much hit or miss. It depends on the person. I find that a lot of people either take too much of it, don't take it at the right time. And the way I was trained was you want to take it when your body is naturally producing it the most, which is typically around sundown. It's not meant to put you to sleep right away. It's kind of it helps regulate our sleep cycle. So when the sun starts to set, our body starts to produce more melatonin, sort of signaling our brain and our body that, hey, it's going to be time for sleep in the near future. And so I'll typically tell patients to take it right around sundown, sundown, not necessarily half an hour or an hour before bed. And I find that lower dosages typically work better. For me, but again, it's very much dependent on the person. I've had a lot of folks come back and say, it gave me terrible nightmares. And we'll stop it. Um, I use magnesium a lot.
Yep.
Magnesium is helpful for me too because it has the dual benefit of treating headache as well. And it's a great natural supplement that really has probably a lot of benefits for the body. And most folks that end up taking it, if they have improvement, despite getting better, they'll stay on it for the rest of their lives because they just like the way they feel.
Oh, I agree. I take my magnesium every day. We use magnesium for different things, especially when we get people with muscle pain, people can't sleep, obviously, digestive issues, even people with our brain fog, right? So we find that magnesium as a whole, even regardless if you run like a magnesium RBC and it comes back normal, it's like, yeah, but they just do better with magnesium, right? I can't say that's a fantastic marker. It's a good marker, but even when in the range, it's still like, wow, they do wonderful with magnesium. It's kind of straightforward. So pigeonhole off of that, if we go piggyback off that, so if we say, okay, we have our concussion patient, and then that patient also has headaches and head pain. So in our practice, and especially because your background is osteopathic, there's a difference between, oh, I have a head pain and I have a headache. And then we have just a tremendous amount of different migraine headaches, right? So before we had ICD-10, go back, 10, 15 years ago, we just had a few migraine diagnoses, and now we have like a slew of migraine diagnoses. So can you touch base with respect to that concussion patient that goes to having concussion and headache and migraine and head pain?
Yeah. So I think I'm of the thought process that concussions often bring out a lot of things in people that they didn't know they had. So, um, certainly, if someone had a pre-existing history of headaches, migraines, some other type of headache, these injuries can often exacerbate them, and they'll say, I went from 1 or 2 headache days a month to every day's been a headache day since my injury. And frequently, I kind of call that a combination of both post-traumatic headache from their injury with an exacerbation of whatever pre-existing headache type they had. Um, I have a lot of patients who come in with no history of headaches, and they had this injury and they've had headaches every day since. It's been 6 months since their injury, and they've had headaches pretty frequently since then. I think the post-traumatic headache that they had initially kind of morphed into more of a chronic picture at that 3-month mark, and I think it takes on the identity of whatever headache it most closely resembles. For a lot of people, that's usually migraine. Um, and I think a lot of people have migraine, probably more than we realize, and a lot of people are actually underdiagnosed. Um, so migraine has a lot of pieces to it. There's a huge genetic component. So I always wonder if these concussive injuries or even subconcussive injuries, if they just kind of flip the switch
Mm,
and make these people headache people.
gotcha. So with the genetic component, is that something how we can look for like the APOE4 alleles? Is there, what do we have the latest looking at migraines genetically? Is that something that's even being looked at?
I'm sure there are smarter people out there looking at that. There are a lot of, like you said, there's a lot of different subtypes to migraine. So there are certain types of migraine. Um, for example, migraine, hemiplegic migraine, which is a migraine that presents like a stroke. It very much frequently has a familial component, so there is genetic testing available for that. But for bread and butter migraine, it's really clinical more than anything.
Gotcha. And can you talk a little bit about the science when those patients who share like the migraine headache is so bad, I have to go into a dark room and I have to have no sounds. Can you talk about the physiology behind why they have to go in a dark room?
Yeah, so patients who have migraines um, are very sensitive. So everything's sort of hypersensitive, and um, it makes sense in the sense that any little thing, whether it's too much light, too much sound, just excessive stimulation from things going on around them, they can all make their headaches worse. And the goal of the body in that moment is to try and turn the volume down, but it struggles to do that during the migraine phase. So most people prefer that quiet, dark room. Um, there's something called cutaneous allodynia, which is another example of sort of that hypersensitivity where anyone just touching their hair, trying to brush their hair, lightly touch their face or their head, describe it like fireworks are going off. It's incredibly painful, and it's just because again everything's so sensitized and just needs time to kind of calm down.
And we've seen that in the office. We've seen them where they couldn't even put their eyeglasses on because just the brush through here and the light frame was enough to just set them off. So when we're talking about overstimulation, obviously, in today's world, my God, everyone's stuck in front of their computers and phones, and it just never stops. I mean, I ask people to get like that. You know how like the office we do the HIPAA compliant filter over the screen, right? So we have that like in my office here. It's like I have one of those, and then I have something on top of it, another filter. I dim it, and then I'm wearing the glasses, and I can tell you that on like virtual visit day on Friday, where I'm in front of 2 screens most of the day, sleep that night is never well. right? So
Yeah.
it's got to be affecting us on so level. So then you think about it in duration over time, there's got to be like it's piling up.
Hmm. Yeah,
So
I mean,
how do you get
screens
away from that?
are yeah, it's hard, especially for people who work on screens all day long. Um, the best advice, I think you kind of hit the nail on the head with all computers nowadays pretty much have a built-in filter. You can put a physical filter on top of that, the blue light glasses. I think breaks more than anything. So it doesn't have to be a long break, but even if, every half an hour, you just kind of look away for a minute or two or a couple minutes and just kind of let things calm down, reset, that can be very helpful. Um, there are specific lenses also that eye doctors can usually work with their patients on called FL41 lenses that do a really good job of really eliminating all of that sensitivity that comes with light. Um, so that's helpful for some of the people who are really struggling.
Yeah, I mean, we incorporate the eye gaze exercises. So you put your little timer on your phone, and like every 20 minutes we want them looking like above the monitor, below the monitor, to the corner of the room. But we also incorporate exercise snacks. Are you familiar with that?
I am not. I'm
Yeah, so
curious.
this Rhonda Patrick, she's got her PhD. She talked about this, and I think it's wonderful. We've been adding a lot. So you roll in front of the screens at 9 o'clock. So at 9:55, you're going to do 10 squats. At 10:55, you're going to do 10 wall push-ups. At 11:55, you're going to do 10 lunges. And I really don't care what the movement is at the top of the hour, but at the end of the usual 8-hour day, we got a ton of movement, right? So you got 8 hours, you got 10 reps of any movement, you're at 80. You work 5 days a week, you're at 400, you're 1600 a month. So when we can add those little things in with the eye gazes and we build in those breaks, it's just a lot easier, you know. But it's also though hard for this concussion patient, headache patient, to get up and move and exercise. And we find that exercise, they know they have to do it. It just increases that pressure in their head greatly. So when you're talking to your patients, we know exercise is so important. What do you do to help them kind of just slowly get back into it? What are you asking them to do from a movement perspective?
Yeah, I tell them all they got to find that sweet spot, the point in the middle between doing nothing and doing too much. And physical therapy is really good at this, and that's why I use them frequently. But the basic idea is you want to incorporate aerobic exercise to the point where you may be becoming a little bit symptomatic, whether that's a headache, fogginess, dizziness. If you're able to tolerate it, it's not debilitating. You can continue beyond that point a little bit, but if it starts to really flare up, take a break. Whether that breaks a couple minutes, 5 minutes, 10 minutes, take a break. If you feel like you can start again and get to that point or even farther, great. If that was it for the day, that's fine, and then the next day, you'll find that you're able to push that boundary a little bit further. So, exercise is key. The old way that we used to treat concussion was quiet, dark room, don't talk to me, don't look at me, just cocoon basically. But we've done a lot of studies that have looked at groups recovering from concussion, and the group that does aerobic exercise consistently recovers quicker.
Gotcha. And we find like if they can get into that Tai Chi, Qigong kind of movement pattern, that's really nice. A lot of times, I'll talk about the importance of balance, and if you can talk about balance, that'd be great. Their balance is off. You
Yeah,
know,
yeah,
that's
balance is a big piece to this. Um, our balance is multifactorial dizziness, balance. Patients describe it in a number of ways, but it could be it could be a brain issue, it could be an inner ear issue, it could be an eye related issue. Frequently, I find that it's inner ear and eye. So, normally when we look around a room, our eyes are already meeting where we need to go, and there's no lag, there's no overshooting, and then kind of coming back to the target. But those things happen after a concussion. So that can impact balance and focusing. But then you also take into account the balance portion of our inner ear, and something as simple as vertigo. Benign paroxysmal positional vertigo is very common after concussion because those crystals that maintain our sense of position can just get moved out of place and make you feel like you're moving when you're not.
yeah, and that's where I think a good vestibular therapist is great. We refer out to, I think it's important. In my world, balance exercises, you brush your teeth every day, you floss every day, you're doing balance exercise every day. We had them do the balance exercises when they're doing their toothbrush. It's a 2 minute default, so we do 2 minutes in the morning, 2 minutes in the evening. We got 4 minutes a day, right? So again, we try to sneak these things in there, so we're not taking anybody's time, just trying to make it lifestyle. But we find that even the use of the electric toothbrush for our concussion headache patient, that sensory is enough to set that off again. And sometimes it's like fatiguing to do something just like standing on one leg and doing ankle rotations. So are there any balance exercises that come to your head that you share with your patient, like, hey, try to work on this one piece versus another? Is there anything like that?
I don't have anything in particular that I would use because I really do rely a lot on physical therapy for their expertise there. Um, but I love the idea of you kind of incorporating activity, breaks, any sort of exercise, just incorporating it into your daily routine because I think that that's really the goal with these injuries is to get patients back to their baseline normal self pre-injury and be able to just function on a day-to-day basis.
And having the osteopathic background I have, when you and I talked briefly about manual therapy, does manual therapy play a role in helping these headache patients, concussion patients? Do you think that's still good to at least attempt a trial?
Yeah, there's a lot of different disciplines that do similar work. So, between physical therapists, massage therapists, chiropractors, osteopathic manipulative treatment, there's a lot of overlap there. Um, I really like the osteopathic manipulative portion, because of that sort of holistic training that we get in school. And again, it's more than just neck pain, it's more than just a headache. You really want to look at the whole picture and see if there are other parts playing a role and treat those.
Yeah. Again, I think good manual therapy definitely plays a role. But it's just so hard sometimes with the concussion patient too. So you want to be cognizant, I think, of your technique as well. Especially, you don't want that head whipping around. That's where I don't think
Yep.
a high velocity, low amplitude visit would be good, right? So that's where the
Yep.
good old muscle energy techniques come into play. All right, so if we can turn the conversation to concussion in the sense of it's now two or three concussive injuries, so they're layered on top of one another. What can we expect? And I know everyone is different, I get that, but what can we expect in terms of 6 months out, a year out? Can we get that person back? I mean, we're going to work on sleep, we're going to work on movement. All that's important. Maybe there's going to be pharmaceutical management. What kind of pharmaceutical management do you like? What can that person expect? And again, I know every injury is different.
Yeah, yeah. I mean, yes, so absolutely, yes, every injury is different. Um, we still view each concussion as an isolated event in time, but there's a lot more research being done on what happens with each of those repetitive injuries. And obviously, there's a lot in the news and football and a lot of things out there on all these folks who've had repetitive injuries over the course of years. Um, Still learning more there, but I'm really of the mindset that if you've had a handful of concussions, let's say less than 10, um, there is always the possibility of getting you back to your pre-injury self. Um, but I find that with each subsequent injury, recovery might take a little bit longer. Um, the mechanism of the injury also plays a role because we might be impacting a different part of the brain, like we talked about initially. And it really depends on what treatment was done up front. So I see a lot of folks who come to me months, sometimes even a year after their injury, and either nothing was done, or not the right things were done. They didn't get the right diagnosis. Um, Headache is obviously a big part of my practice, but that's one thing I see consistently that a lot of people just don't have their headaches treated because they expect them to just go away, or they just get caught up in this loop of taking something over the counter every single day and don't know that that's actually making their headaches worse. So I believe that we can get people back to their baseline. I think it just depends on what we're dealing with, and there's often a lot of other pieces at play.
Gotcha. So in my world, we'll look at the importance of fish oil, CoQ10, creatine to help the brain. So you're familiar with those stuff, but where are we at from a pharmaceutical management perspective? Is there anything that you think about? And again, everyone's different. I get that, but anything you think about, like from a concussion patient, anything pharmaceutically that we can support? And we know there's a for a reaction there's a reaction, but we don't want to create anything. So do you use anything in your practice from that perspective?
A lot of my medication approach, if someone needs it, really revolves around headache. I try to avoid prescription medications as much as possible. But if it's been, 6 months, let's say, and they've had a daily headache, I think it's time to be a little bit more aggressive with treating that and really try and get them back to where they were pre-injury. I don't have anything that I would definitively use consistently for someone who has lingering symptoms. Again, it really depends on what else is going on. Um, Frequently using the magnesium. I use riboflavin a lot for these folks. I find those to be helpful for not just headache, but just some general functioning as well.
Gotcha. And any history, like you use any of the CoQ10 fish oils, anything like that, the specialized protozoal mediators, like a higher
My
decreasing the inflammation?
my usual concoction is magnesium, B2, and CoQ10.
Gotcha. And my CoQ10 intake is 200 milligrams a day. What do you normally share? What do you think? You win them at 100, you win them at 200?
Usually around 200 milligrams a day.
Gotcha. Okay. And that's whether that's concussion and headache patient, right? I mean,
Mhm.
both can benefit from that greatly. You know. So
Absolutely. Yeah.
one of the things we talk about treatment, there's also especially headaches, there's from trigger point injection, nerve blocks, Botox, and you also provide other types of injections. Can we talk about what you provide in your office from that injection perspective? And when you say injection, a lot of people they get scared about that, like, oh God, they're going to stick it in my head, kind of stuff like that. But if we talk about the injections and how they really help, because we find them to be very helpful.
Yeah, so I agree. I think they're very helpful. I think they are frequently necessary for some of the more chronic headache patients. Um, can be very useful in the acute setting after an injury as well. So I do a variety of different injections like occipital nerve blocks or other nerve blocks, um, trigger point injections, which are similar to those. Sphenopalatine ganglion blocks or SPG blocks and Botox. So uh, if I start with the nerve blocks, the biggest one that I do is occipital nerve block. So they're these nerves in the back of the head that kind of come up and travel forward, and they're encased in muscle. And so frequently, when someone has a whiplash injury, or they hit the back of their head, or they just have a lot of tension in their shoulders and their neck, where everyone carries their tension, those nerves can get irritated. And a nerve block is a fairly simple procedure that we do in the office with just a little bit of numbing medicine, lidocaine. And what it does is it just kind of shuts down those pain pathways temporarily. So I think of it like hitting the reset button on a computer. And when the computer reboots, less of those signals are firing, which is the goal. So oftentimes it can give patients a lot of relief up front. The goal is for an extended period of time, but sometimes we need to do them every 4 weeks for a period of time. But it also gives patients the opportunity to participate more in different therapies that can help relieve some of that tension in the muscle that may be causing that in the first place. Um, SPG block, so the sphenopalatine ganglion is a bundle of nerves kind of located behind the nose in the posterior aspect of the nose. And it's a relay center for a lot of the pain signals related to a variety of headache disorders or facial pain. So it's a great place to target for someone who might be struggling with these things. Um, and that's fairly simple. It involves just taking a catheter or a long Q-tip with numbing medicine on it, and really just getting going up into the nose and up towards the ganglion itself and just numbing it. And same sort of idea as the other nerve blocks is to kind of shut down those signals temporarily, gives them that quick relief that patients are looking for, but can be very effective at treating their pain. Um, Botox is great. Botox is FDA approved for the treatment of chronic migraine. Um, when you tell someone about Botox, they immediately think about cosmetic Botox and wrinkles. And it has some sort of benefit there, I guess, because we are injecting muscles of the face, the head, and the neck. But the focus is these approved areas, these studied areas around the face, the head, and the neck that we treat with Botox, and it kind of has dual benefit. So it can be helpful for the muscular component by relaxing a lot of those muscles that may be contributing to headaches. So I find it to be very helpful for a lot of chronic migraine patients who also have a lot of tension in their neck or their shoulders. Um, what it also does is it prevents the downstream release of a lot of those pain generating proteins that are ultimately thought to cause the migraines themselves.
Gotcha. So let's go back to the SPG injection, the pseudopontine ganglion block. So you said, oh, it's just simple. We're just going to stick it up there, right? But you remember, the patients, we're going this way, right? So what are you
So
looking at when you're doing it, right? Are you
yeah, so
going
we're going this way. So I usually have them lie
right?
flat on their back, and we numb up the entrance to the nasal cavity so it's not terribly uncomfortable. And it's just taking a long Q-tip with that numbing medicine on the end, sometimes with a catheter on the end, depending on the technique you're using. And the goal is to kind of bathe that bundle of nerves with the numbing medicine. Um, to stop those signals from firing. It's generally pretty well tolerated. Um, Obviously, you're putting a Q-tip in your nose, so it can be a little uncomfortable, which is where the numbing medicine kind of along the surface or the tract can be helpful. Um, Most people don't have any issues with it. You might have a little bit of a bitter taste in your mouth, which is normal, um, but generally people do very well with it.
And can you share, like, what is there a specific clinical presentation that you're looking for to apply that procedure? And like, how long can they begin to experience the benefits from that?
So there are a lot of different patients who could benefit from it. So it's very helpful for people who have facial pain. So people with something like trigeminal neuralgia, which is one of the nerves that provides sensory input to the face. Trigeminal neuralgia is pain in that nerve distribution. But a lot of migraine patients or other headache patients can have a lot of pain really focused around the sinuses, in between their eyes, around their nose. And it can be very helpful for those folks. Um, Typical relief would be ideally hours to weeks, anywhere in that range. It very much varies depending on the person. But again, the benefit to this is that we can do it fairly frequently if we need to, um, and give them that relief that we're looking for. Sometimes patients can even do it at home on their own if they needed it more frequently.
And we're talking about the relief of the head pain, facial pain, that kind of stuff, not so much the symptomatic presentation of a concussion. Or is it one of those things where the pain level comes down and then those concussion symptoms also dial down?
I think a lot of lingering symptoms after concussion are often linked to their headaches. And that's something I see really commonly where people will come in with a long list of symptoms after their concussion. Headache is a prominent part of that. And, we address all the pieces, but we focus on treating the headache as part of their initial eval. And a lot of times, as we treat the headaches, a lot of the other symptoms get better.
Gotcha. So in a lot of times we'll see this with an accident with concussion or not, and that's the tinnitus or tinnitus, however you like to pronounce it. Um, Ever see SPG change that at all?
No, I haven't. I think tinnitus is complicated. I think even ear, nose, and throat doctors would say tinnitus is complicated because we don't fully understand what causes it. Um, we do see concussion and tinnitus frequently coexist, and um, you know, I, I can't say that the SPG block would necessarily make a big difference there. But again, going back to that headache piece, I do find that a lot of times when we treat the headaches, because a lot of these folks have them daily after their injury, it can help with the tinnitus too. Doesn't necessarily get rid of it completely, but it can certainly help maybe turn it down.
Yeah, I think the person who fixes tinnitus will be on the cover of Forbes within a week and the Nobel Peace Prize for sure, right? Because it's just so worldwide, and we just don't have an
Yep.
answer what to do with it. We don't even know why it starts sometimes. It's absolutely just one of those phenomena is like we can't seem to get that under control. Um,
Yeah.
for sure. So
Yeah,
anybody that does that, it'd be wonderful.
yeah, it's debilitating. I mean, it definitely impacts everyone, every aspect of your life.
Yeah, yep. And again, but the cognitive behavior therapy, there's some good CBD programs with that as well. They have something you can stick in your ear, so instead of hearing that, you're going to hear a different sound, whether you like birds or an ocean sound. So it just dials down that kind of upregulated sensation, which you always hear that. Like, here we go again, and just
Yeah.
not really good for the, put you in that very upregulated sympathetic system versus parasympathetic, So anything you do to
Yeah.
wind that down, it's always great.
Yeah.
All right, so if it's okay with you, I have some questions because some patients give me some questions. So if you would be open to answering some of those thoughts and
Sure.
questions. Okay, so can you talk a little bit about, we briefly touched on it, like when somebody has head pain related to a CSF leak, can you talk about that a little bit?
Sure. So, um, the brain and the spinal cord are surrounded by fluid called CSF, cerebrospinal fluid, and um, for some folks, this fluid has a pressure level to it. For some folks, the pressure level can be too high, which is a different type of condition in itself. But with the CSF leak, pressure is a little bit low. And there's a lot of different causes of CSF leak, but the two more prominent ones are probably traumatic. So something that physically disrupts that covering around the brain or the spinal cord that produces a bit of leaking and drops that pressure, which causes discomfort. There's also spontaneous intracranial hypotension related to a leak, and um, the thought behind that is that maybe these folks had some sort of genetic susceptibility to um, weakening of that layer. So we see that with a lot of connective tissue disorders like Marfan's or Ehlers-Danlos. Um, but what happens is essentially, you think about gravity when if you have a leak and you stand up, sit up or stand up, the pressure is going to drop even more. And these folks are going to have a lot of discomfort, headaches. They'll have a variety of other symptoms, dizziness, sort of disorientation. Um, and the key to treating that is number one, determining if they have a leak, which imaging can be very helpful with beyond the clinical presentation, and then plugging that leak.
Gotcha. All right, and then next we have is, and somebody asks us, can you talk about what happens, any information you can share when there's a temporal fracture, when you get a fracture?
Temporal bone fractures, is that
Right.
what you said?
Yep. Yep.
Yeah, so there's a lot of vasculature in that area, so that's certainly something you want to think about. If they had a temporal bone fracture, you want to think about the mechanism and the degree of injury they had. So, if someone has a concussion, they don't typically have something like a bone fracture, so they may have had a more significant injury. And then the question is, well, what sort of symptoms are they dealing with at that point, and what would be the next best steps?
Gotcha. Okay. And then another one I have here is like, can you share? I know times like, I got a headache. I'm going to go to urgent care. And I always tell people, hey, headache, chest pain, not that urgent care is bad, that we love them. Skip and go to the hospital, right? So can you share some red flags like, hey, this is a trip to the hospital? Because some people will still blow off that headache. It's just a headache. I'll take a Tylenol and Advil, and it should go away. So can you talk about the importance of time, right? Because that time is important. Like, hey, let's go right to the ER room.
Yeah, so I think number one, if it's a sudden onset headache that you would describe as the worst headache of your life, even if you're a headache person, I would say that warrants a trip to the ER for imaging. Most urgent cares can't do imaging, and the goal is to rule out any sort of bleeding or secondary injury in the brain that would be causing that terrible headache. If there's odd symptoms with the headaches, weakness, changes in your speech. Um, Numbness, tingling that you haven't had before. Those are things to look out for. If you have a fever or you feel ill, that would be a reason to go to the ER as well. Um, it gets complicated because, like you said, there's so many different types of migraine, and migraine comes with so many different symptoms. Um, I really dive into that history more because a lot of people with migraine will get numbness and tingling before their migraine, and that's normal. Um, but if someone has something like what I mentioned before, the hemiplegic migraine, where it's presenting like a stroke, I don't know in the moment if it's migraine or if it's something else. So I have to tell those people to go to the ER to get imaging to make sure that we're not missing anything more significant.
Gotcha. Those are great. All right. So in our remaining time, I want to learn more about your practice. So you have a concierge practice. We heard people having concierge practice, but you have a neurologic concierge practice, which is absolutely phenomenal. You kind of hit it in the very beginning. It's like you want to spend the time with the patient. We hear this constantly that my doc doesn't have the time. And I know a lot of these doctors, and they don't have the time, not because they don't want to take the time, it's just they just can't do it, right? So can you talk about like what made you go concierge practice other than you want to take it, spend more time with your patients, do all the cool stuff, but that's stepping out. So that's really cool. So congratulations on that. But can you talk about what's it like when somebody comes to you? Well, I'll just use my insurance and go to this guy here. Why isn't that the same? But you and I know it isn't. So can you talk about that?
Yeah. Number one, I can see someone within a couple of weeks as opposed to months, which was at my previous location, um, which for me is important because, for what I treat, which is primarily headache disorders or concussion, it's hard to wait months, and when someone comes to me 6 months after having an injury, but they haven't had any treatment in between, we're really playing catch up at that point, and it prolongs their recovery. For someone having a daily headache, waiting months is unacceptable. So the goal with this clinic was to be able to get people in much quicker, have the flexibility to do that, so not be constrained by any outside influence, and give patients the time that they need. So the biggest thing that I do for most people when they come in is just listen. Um, listen to their story, and I don't need their whole life story, but just listen to the story about why they're here today, and um, educate them. There's still a lot of misinformation around concussion out there. There are a lot of medical providers who don't know how to explain concussion well. So most people that come in don't really understand what's going on. They end up Googling things, and Google's great for a lot of things, but it takes you to lots of random places sometimes. So my job is to listen and to educate, and this clinic gives me the opportunity to do that.
Very cool. So can you share like, what's it like when somebody comes in? Okay, you walk through like their roadmap. So, most of them have been somewhere before, right? So you have a nice interview, go through an exam, and then is there a thought process of like, okay, what kind of procedure you're going to have? Because again, the insurance does not cover this, right? So as a concierge doctor, is it something you see them every week? You see them once a month?
It depends on the person. If we focus on headache for a minute, so I have two different models. So for some of the folks who are having headaches infrequently, they have migraines, but they're not monthly, they're not daily. Maybe every couple months they get a migraine. They have some other headaches mixed in. Those folks might need to see me every 4 months or so. If you were someone with chronic migraines who we've tried X, Y, and Z, and now we're doing Botox every 3 months because that's how it's scheduled, and we're maybe mixing in other procedures periodically, they might fit better into the membership model where, I'm seeing them every 2, 3 months or a little bit more consistently and frequently because they need it. Um, so it just depends on the person and the trajectory that we go in really just depends because it's so individualized from both a headache standpoint and a concussion standpoint. And, like you said before, every injury is different, every person's different. So what direction we decide to go in with procedures, medications, supplements, therapies. It's so varied, but we have so many options.
That's excellent. And you had mentioned that it's you can see them now because it's so hard to get in to see a neurologist. What has happened in your opinion? Do you feel like it's so hard to get in? I mean, what occurred? Do we not have enough docs? Do we not have enough new docs?
I think that's part of the problem. I think after COVID, I think there was a large departure of physicians, and there's always been a dearth of neurologists. That there's never been enough neurologists, and um, previously I was seeing 4 to 6 new patients a day, and that's a lot of people to see, and then to follow up with, it's impossible to get people in. So. Um, the goal here is to have a smaller practice, be available, be the go-to guy, and not have patients need to jump through hoops to get what they need.
And we hear that. So I'm sure that you have some kind of portal where they can contact you, all that kind of stuff. Do you also do virtual visits as well?
Yeah, so I do virtual visits, I do in person. I'm happy to do my first visit virtually if someone needs to as well. Um, the beauty of headache medicine and concussion medicine is that I can do a lot of things virtually. I can get a really good idea of what's going on just talking to them. And then when it comes to the exam, obviously I can't do some of the hands-on um, you know, muscle testing and things like that, but you can get a general idea of how someone is doing just by watching them stand up on a screen, walk around, squat down, um, and look at their eyes, how they're moving. There are a lot of things you can do through telemedicine and still efficiently treat them.
Excellent. Very cool. I really thank you for your time. Is there anything else that you would like to add? Like if you think like from a brain health perspective, right? What are the top three things for somebody to do when we talk about brain health? And we didn't even touch any neurodegenerative. That could be a whole nother hour for neurodegenerative. What are the top three things that somebody can do for brain health?
Activity, be active, whatever that means. And when I tell some of my patients who aren't normally active to be active, uh, they don't need to go and run a marathon every day. They can do something for 10 minutes, 15 minutes. And there's so many ways to be active now. It doesn't have to just be like scheduled physical exercise. Simple things like gardening, doing things out in the yard when it's not so cold. Those are great ways to just be active and incorporate that on a daily basis. That's important for longevity. It's important for helping with headaches, mood, thinking. There's so many benefits to activity. So that's one. Consistent sleep. Obviously, if you have something secondary impacting that, like sleep disordered breathing, or, in my case, a young child, you do your best with what you're given, but consistent sleep schedule, trying to get good quantity and quality sleep will take you a long way. And diet, there's a lot of different types of diets out there, but I think just being healthy in general, eating a healthy diet, avoiding processed food as much as possible, which is hard nowadays.
Mhm.
Um, but just doing your best to kind of maintain a healthy, balanced diet along with activity and good quality sleep can take you a long way.
Excellent, excellent. That was great. And just the last question I like to ask people when I speak with them, and you're only working 12, 14, 16-hour days, and now have this new concierge practice. What book are you reading?
Oh, book am I reading? That's a good
Yeah,
question. Uh, how to be a dad to a second child. My wife's due in a few months, so
nice.
um,
Yes.
yeah, it's going to be a game changer from what I hear. So, trying to balance the whole, run a business, be the plumber, the handyman, the painter, and um, maintain a household at the same time.
Yeah, not an easy task. So, but
No.
a wonderful task, right? A wonderful thing to do.
Yes, absolutely. Yes, very
And
exciting.
I will tell you, with older children, and they always tell you this, the time goes by fast, and it does. It
I
surely
bet.
does.
Yep.
So, you enjoy it. You're in there for the ride. It's all wonderful. So thank you so much for your time today. I really appreciate this. Everybody, there's going to be a replay on YouTube and Facebook. If you have any questions, reach out. Dr. Patel, can you share everybody like how they can get in touch with you?
Yeah, so if they want to go onto my website, it's www.clearpathneurology.com. There's a lot of information there. There's an FAQ section if there's any questions that go unanswered. If the website doesn't clarify anything, they can book a 15-minute virtual meet and greet with me, which is free. There's no charge, just to talk and see if we'd be a good fit, or if I can help you. And they can also book their consultation through that as well.
Excellent. So very cool. Thank you very much for your time. Thank you for everybody watching, and we'll talk to you soon. Take care.
Sounds great. Thank you.